Okay, hello everyone. I think we should be starting. So I would like to welcome all of you to this very interesting first session of the program. I'm happy to be chairing this session. My name is Shadi Saleh. I am the director of the Global Health Institute at the American University of Beirut and a professor of health systems and financing. It's a pleasure to be with you for this session on reframing fragility, implications for strengthening health provision in diverse contexts. And I'm happy that we have with us an exquisite group of speakers who I will be introducing one by one. Perhaps we can start with our first speaker for today, Dr. Alastair Ager. Just a couple of housekeeping comments. The first is that each speaker will be talking for 10 to 12 minutes, followed by 3 minutes for clarification questions, and we will leave the Q&A session until the end of the speakers' talks. If you have questions, please make sure to include them in the chat box. So to start off, it's my pleasure to introduce Dr. Alastair Ager. Alastair is the director of the Institute for Global Health and Development at Queen Margaret University, and he is also the director of the NIHR Research Unit on Health in Situations of Fragility, which we are part of at the Global Health Institute as well. In addition, from 2017 to 2020, Alastair served as the Deputy Chief Scientific Advisor to the UK Department for International Development. Alastair, the floor is all yours.
Thanks ever so much, Shadi. And whether you're listening live or people are listening to this in playback later, it's been a great pleasure to work with Shadi and his colleagues at AUB, and with our colleagues at COMAS in Sierra Leone, Hajawuri and her colleagues, as well as with a number of folk at Queen Margaret University and collaborators across the world, including Ananda Galappatti, who will be speaking a little later. It's my great honor to just start this symposium, our 4 sessions of brief reflections on work over the last 4 years, by really just questioning this term that's in the title of the research unit, about fragility, with the research unit on health in situations of fragility. And from the outset, were focused on this term, what it meant. And I want to suggest in the next 8 minutes or so that it's an important term and one that we've learned much about, but we have much more to learn about in terms of its implications on health. If we can have the next slide, please, Karin. So I think one thing we've learned over the last 4 years is some good reasons not to study fragility, that there are lots of barriers and lots of difficulties with the term and with the understanding of it and with the engagement in it. And one I want to flag right at the outset, and it's a serious issue, is that no one really wants to be fragile. We came into this work from the Queen Margaret perspective, very much on the back of work on resilience, and resilience is a concept that is also problematic in lots of ways. But one understanding of resilience is that it's basically an attribute that people are eager to have either as an individual or as a system or as a nation. One of the things that led us towards the understanding of fragility is that whilst resilience is important, to understand the potential threats, to understand weaknesses, to understand vulnerability, we do need to go beyond a blithe belief in just strengthening things and strengthening resilience to understand some of the threats, some of the challenges that are faced in environments, and that fragility is relevant in that thinking. We're going to be arguing, but nonetheless, we acknowledge that it's a deficit concept. It's a concept that talks not about strengths, but about vulnerabilities. And there's a place for that, I think, in our thinking in global health, but we recognize that it's one of the things that creates a barrier for us talking about fragile environments, fragile settings. A second reason why I wouldn't commend it to be an easy area of study is that we seem to have got stuck with the label of fragility in terms of our understanding of fragile and conflict affected states. And there was a time, potentially, arguably, when it was a valuable term to use in terms of that cognate term, fragile and conflict affected states, to signal particular environments that warranted a classification that benefited them by particular forms of development provision and funding to support development. But partly linked to that being a pejorative label, not many people actually want to be classified as a fragile and conflict affected state. And it's rather led to a stasis in our thinking about the concept of fragility that we want to urge more engagement with, by thinking that essentially it's a label. You either are fragile or you're not fragile. And if you're fragile, you're in this list of countries, you're in this list of states that bears certain threshold of fragility which warrants that attribution. And indeed, then the pejorative concerns about being labeled a fragile state. And the third reason that I think there's a difficulty in studying the term of fragility, not just that it's a term people don't want, not just because it's got stuck in terms of fragile and conflict affected states, is that in our thinking, it often is just such a woolly term that it's used as a substitute for just being a weak system, for example. What's the difference between a fragile system and a weak system? It's just showing that there's a lack of capacity, whereas it can mean something rather more than that. But generally, it's just used as a characterization of deficiency and of weakness. The next slide, please. So those three concerns are very real ones, but I want to put a counterpoint in my just initial remarks to suggest why, over the last 4 years of our work, we think that there has been real value in studying this concept of fragility, and indeed warrants further investigation and further building. The first is that for all of that notion of it being vague and superficial, there's actually some now very strong analytical work pointing to distinct dimensions, characteristics of fragility. And Karin later on will be talking about some of the work of the OECD, which is reflected a little bit in that figure at the top right of the screen of 5 particular dimensions of fragility. But it's really something that does have some analytical power if we give it time and space to consider that. Secondly, and I think this is a very powerful argument against the pejorative labeling of particular states as fragile, is that the experience of COVID-19 has shown that there are aspects of many health systems, much provision, that in the wake of particularly strong shocks could be seen to be fragile. It's not a characteristic of a subset, a minority subset of systems, but in particular circumstances is a characteristic of many health systems, even with high income settings and even with strong governance. And to understand that weakness, that fragility, is really an important global task. That links to this third point, that if you understand something as being fragile, it's about the connections not quite fitting together, or it's a question about those connections not being reliably made. And so you'll see in many of the presentations today, and also tomorrow, for those of you who join that presentation, that when we're looking at fragility in a system, it does draw us to review the system as a whole, that whole system for health, and not just looking for deficits, but looking for gaps, looking for failed connections, looking for vulnerabilities that don't utilize many of the resources that are available because of the lack of connection, the particular vulnerability. And perhaps the most important reason, and why I've been really delighted to have been involved in this work over the last 4 years, is this is not just an abstract reflection on circumstances and analytical terms, but it's something that really then does lead towards clear direction, towards strategies for systems interventions that improve access, equity, and quality of health provision in these environments. And I want you to see in a couple of slides I'm going to share now, but you'll see them in much deeper illustration later in this session and in subsequent sessions, the way this fragility lens has enabled to zoom in and to really get an understanding of where the particular weaknesses, failings, lack of connections, fragilities are, and how those might be remedied. The next slide, please. So in our early work, this is the first, essentially the first major publication of the research unit over time. We had an editorial in the Bulletin of the World Health Organization, and I've highlighted just two key phrases from it that I think are part of our shtick, part of our argument that I think is important for you to understand subsequent presentations. One is this notion that fragility is not just limited to these fragile complex affected states, and we are happy to work in those and to consider those environments, but our analysis is something that draws us beyond those to look at broader systems factors, and that understanding of fragility is multidimensional. It's not just related, for example, to conflict, but following the OECD lead that Karin will briefly note about, also societal, political, economic, environmental dimensions. The next slide, please. The other key element of some of our early publications was this notion that fragility, we are interested in fragility within a health system, given our focus on health. But we also recognize that in many of the environments, there are fragilities in the relationships and the structures and the capacities of communities. And so to look in a fragile environment is not just to look at the fragilities within the state provision, for example, of healthcare. It's also to look into the capacities for communities themselves to access resources, tensions within communities, etc. And then most crucially, between those two perspectives, fragility between the state and communities as a hallmark of many fragile environments, of where there is a breakdown at this interface between state structures, state capacities, and the needs and agendas of communities. And the final assertion then on this slide is that to understand those dynamics, much of our work has been influenced by complexity thinking and thinking about complex systems, and particularly the use of, for example, group model building. And I want to just end my remarks with a couple of slides on that. If I can have the next slide, please. So this is an example. I just want to highlight two early pieces of work. This is work by Aya Nubani and colleagues working with Shadi in Beirut, looking at the access to mental health services within Lebanon, particularly in Beirut and Bekaa regions. And I don't present this figure to interpret to you now, but just to document the idea that what this figure is representing in terms of the data collection is on the right-hand side is about the mechanisms of accessing care and the interdependencies, the systems factors that influence whether someone will be successful in accessing care or the quality of that care. And on the left-hand side of the diagram are the factors that might exacerbate mental health conditions or seek to ameliorate them. And what we see here is not a linear building block model of a health system, but rather a complex dynamic which has particular points of strength, but also has potential points of fragility where there will be a mismatch between needs and the capability to access resources. The next slide, please. And this is the last slide, and this is just an illustration of a similar phenomenon, in this case in Sierra Leone, and in this case looking at the perspectives of NCD providers. We were particularly interested in mental health and NCD provision in the course of our work, because we see that the continuity of care required for both provision for NCD and mental health is a particular challenge in connecting communities with the state and connecting the services of the state over time. And so here in this diagram, we have an understanding of, from the perspective of NCD providers, that the journey, if you like, in terms of accessing potential services, but also highlighted in the orange boxes where participants saw, okay, this system works, but the points at which it's weakest, the points where the pattern is broken, the system breaks down, is particularly in these areas. An intervention in those areas will bring benefits not just to those factors, but strengthen the system overall. And so that's why I've been very pleased to be studying fragility, and why I think it's important, in that it leads us to understand ways of improving services, and it leads us to understand the broad systems for health and those interactions that are important to sustain, to support health provision. So that's my introductory remarks. I'm happy to have any points of clarification, but basically that is to set up Karin shortly to give a deeper analysis of some of our thinking of fragility, and then other colleagues to illustrate work more broadly. Thank you very much.
Thank you, Alastair, for setting the stage for actually the whole symposium. It's been a very interesting few years working with you and with colleagues on the issue of fragility in different contexts, whether it's in the Middle East or in Africa or elsewhere. And definitely thanks also to Karin and the team who were active participants in this. Ladies and gentlemen, as I said, if there are any pressing questions, clarification questions to Alastair, please go ahead and or any of the speakers, type that in the Q&A. Since I do not see any questions, we will move into our second speaker, who has been actually instrumental in this whole project, Dr. Karin Diaconu. Karin will be discussing with us the evolving conceptualization of fragility and implications for global health. Karin, the floor is all yours.
Thank you very much. Thank you all for joining, and it's really been a pleasure to work on this project, and I'm hoping to share some of the lessons really that we've learned across the last 4 years with you. Right. So just briefly an introduction to how we went about exploring fragility. And I think as Alastair and as Shadi noted, we really conducted quite a wide range of studies into this and tried to focus our work as much as possible on any kind of studies really capturing or elucidating the concept. So we first carried out a scoping review, which I will report on in a minute. We also carried out quite comprehensive country case studies. We focused these on non-communicable diseases, NCDs, and mental health and psychosocial support, or MHPSS, excuse the acronyms. And again, the case studies are quite varied. You will hear presentations across today and tomorrow across these, so I won't go into detail, but I'll capture some insights maybe. Most of these case studies, I should say, were carried out in Lebanon and Sierra Leone with the help of our partners at the American University of Beirut and the College of Medicine and Allied Health Sciences. But equally, we have invested across this grant and consortium really to conduct further work in other settings to see how generalizable some of our findings might be, what else we could learn. So, for example, in El Salvador, Nepal, and Nigeria. And finally, we really tried in the last year particularly to look at conducting broader syntheses or to invest in commissioning reviews, for example, that could capture insights that go beyond single case studies. And again, the whole purpose here was to try and really identify, well, not just what is fragility or why is it helpful, but what utility does it bring when we really apply it to different topics. So I'm going to start really with telling you a little bit about the scoping review that we conducted early on. And this was very much at the start of 2017-18 when we were starting to think, well, how has this concept been used in literature? A number of us had obviously already worked in fragile and conflict-affected states or settings for quite some years. But then again, we noted that even in the literature in 2018, for example, the OECD States of Fragility reports were starting to come out. This has been updated since then. And the concept had started to be used in a much broader sense than maybe we were expecting. And what we really wanted to know, well, what does it really stand for today at that point in time? And so we conducted a scoping review, really very broad, and we used concept analysis really because we felt it was essential to try and identify, well, what's really defining this concept and what really has just become noise surrounding it. So the scoping review, again, very broad, quite the labor of love, I should say. We looked over 4,000 really articles, narrowed those down to 377. And it might not be surprising, but for some of you who've worked in this field for quite some time, only 55 of these articles actually referenced or included very specific definitions of fragility. And I think those definitions are the ones that you will be most familiar with. It is either the definitions provided by the OECD, the World Bank, the Department for International Development at the time. And again, those focus mainly on the same kind of concepts that Alastair has already emphasized. It's the state's inability or potential lack of willingness to offer basic services. There's a lot in those definitions about conflict, essentially disrupting essential services. But then in 322 other articles, that was not always the case. And they really spoke about fragility in a much broader sense and couldn't tie their own thinking to these definitions that were already out there. So what we did obviously was extract data on kind of the usual things, but more so on the definitions that were used or the actual quotations that were linked to the concept of fragility. So anything that was felt relevant was extracted and then qualitatively really analyzed. And this is just a graph to show you, obviously, if we would update this now, it would look quite different. But up to October 2017, we could see this increasing trend that more and more papers on fragility were coming out. And again, after COVID-19, I expect you will have seen even the number of webinars that are using the concept has gone up. So again, I expect this trend will continue to go up. So what did our papers, when referencing the concept, what kind of settings did these really describe? And again, what was surprising to us at the time was there was a large body of literature focused on sub-Saharan Africa, probably unsurprisingly trying to document weaknesses in health systems or low resource health systems and equally governmental systems more broadly. But increasingly, we started noticing, okay, there's more papers really coming out about, for example, North America, Europe, and Central Asia, places we hadn't really expected. Again, South Asia, East Asia, and Pacific as well. Places that, again, maybe did not have quite the same history or were not referencing the same kind of history of conflict. Very few cases of those, but more broadly, for example, papers from Japan, Norway, focusing on very different challenges around offering person-centered care or integrated care. And that again meant that fragility to those authors and in those settings might mean something different. So when we tried to really make sense of this, it seemed to us that fragility had been applied at different levels across the literature out there, either to study a within-country phenomenon or to really capture dynamics that were discussed at regional levels, state levels. Or it was used very much to refer to different things. That's what we would call the referent. Either it was used to describe a context, and again, for example, then it might mean low socioeconomic development of a country, it might mean environmental context. But equally, it started being applied more broadly to population and community capacities. How do communities interact with the health system? How does the health system actually cater to their ability to take care of themselves? That's what, again, the health system and population interface, how do the two communicate? Who is the health system accountable to? For example, that was quite a recurring theme in our work. And equally to the health system itself. So is it well-resourced? Is it functioning well? Is it coordinating service delivery appropriately? Is it offering quality care? And all of those we started seeing being described quite distinctly in literature. And then there was a lot of application of fragility in relation to stressors. And yes, of course, in relation to security and conflict, but more so recently, chronic stressors, chronic economic stressors, political stressors, environmental challenges that affected entire regions. So for example, famines, droughts, all of that was coming up more and more. And this was in 2017. So since then, the world has changed. And again, we'd expect more of these to come up. So the presentations in the next 2 days really highlight what our country case studies have shown. But again, what I wanted just to pick out here is the broad fragility influences. So what does fragility really affect? And again, the diagram here on the right highlights what the OECD 2020 States of Fragility report emphasizes, namely that fragility relates to diverse landscapes of risk. So maybe instead of us conceptualizing fragility or a country or a setting, region as fragile or not, we should more or less think about, well, what would it be like if it encountered a risk and how ready is it to respond to it? And those risks might be economic, environmental, political, security related, or social. And again, of course, yes, there is a level of grading then to maybe some countries would be able to respond differently than others. But again, it's a bit more of a, I want to say, delicate narrative that emerges around readiness to respond to risk. So what we found really is that fragility relates to the health system and its preparedness and abilities to respond to stressors and mitigate risks, to also adequately adapt to the needs and the preferences of populations. And you'll hear a little bit about that, particularly in the COVID presentations tomorrow, so I urge you to please attend. And also to coordinate and channel resources appropriately. And that's not just in response to their national threats, but increasingly to trends that might emerge regionally, globally, particularly I'm thinking in relation to NCDs. We then also found out, obviously, fragility referring to populations themselves. And again, you'll hear a lot here about how fragility might impact preferences for seeking help or accessing services, or actually how it might relate to the risks that populations are exposed to, both at one moment in time, but also over longer periods of time. And then it also obviously relates to the links between these populations and systems. And what became very interesting to us across our case studies, again, you will see, is that sometimes health systems really focus on identifying communities as patients. And so they emphasize a kind of patient-centered model of care where people in communities are passive recipients of services. But actually, that's not potentially the way to go forward, because again, the more communities we have, the more we have to pay attention potentially to integration challenges, but equally to accountability models or to models of engagement that are promotive of equity and accessibility. And then what we all equally found is that communities might view health systems as extensions of broader governance structures. And again, that has implications for utilization of services. So finally, I'm going to conclude on this slide, which just looks at or tries to showcase a new fragility framing that we would like to propose. So you will see here on the left-hand side, these landscapes of risk that are very much in line with OECD framing. So trying to identify that there are diverse types of risks that might affect, for example, health systems, communities. But then equally that there are two main domains that we can see emerging in relation to fragility. One at the bottom really focuses on community engagement in shaping what Alastair calls the systems for health. So very much trying to understand how state capabilities and resources would influence the resources of communities themselves and how they might reinforce or address marginalization. How that in turn might relate to utilization of health services and overarching over time in population might result in population well-being or health. But equally at the top, we saw another focus related around the political economy and the financing for health service delivery. We purposefully said here for health service delivery generally and take a very broad systems for health framing, because it might be that care is delivered via public, private, informal providers, sometimes traditional healers, for example, in many settings that fall out with what we formally would call the health system, but again, that are very important again, to reinforce or either to try and achieve equitable, affordable delivery of health services. Overall, in our work, we identified community trust in public institutions and governance as particularly important, and you'll hear two presentations about that, so I'm not going to go on this. But one thing to also flag is we identified that fragility, both these foci of fragility, if you like, are not just impacted by risks and by the local and national health systems and communities, but also by local and regional actors and the ideas and interests that they have in shaping or in trying to sustain diverse health service delivery. So particularly in the NCD session, you might hear how increased emphasis on addressing NCDs really has shaped these foci. I'm going to stop here. Thank you very much.
Thank you, Karin, for an interesting talk, and definitely both your presentation and that of Alastair have set the stage for both days, whether it's the rest of the session today, the second session today, and the two sessions tomorrow. So, Karin, there's a question from a colleague, Johnny from London School. She's asking, or he's asking, I'm very happy to see ex-colleagues from Edinburgh, Lebanon and Sierra Leone running this interesting symposium. The question is regarding the potential of developing a validated framework or tool to assess fragility of health systems across countries. The complete to say, I guess it may be challenging to develop such a fragility assessment tool due to the different social constructions or conceptualization of the term. I think that perhaps this is a question that both Alastair and or Karin can respond to, but definitely something perhaps to build on the OECD also, composite of countries in fragile contexts. So perhaps Karin, you can start, and then we'll move to Alastair if he would like to respond to that as well.
Yes, no, absolutely. Very briefly, I think you've already captured that. I think it would be very difficult to do, but there have been some attempts already, for example, to assess health systems, even just a readiness, for example, in light of COVID, which some fragility elements that I spoke about are already captured in those assessment tools. So if it's focused on the health system itself, I think that would be fine. Again, the broader framing, we might still want to look at that. And I think that's what we're proposing. It's not just about the health system itself. We need to take a little bit of that broader political economy and community lens as well. Alastair, I don't know if you want to.
Yeah, I'm very happy to have a longer discussion about this later, but thanks, John, and it's great to have you joining us, and I hope your work's going well. And just to reinforce Karin's sort of aspirations, I think, for this, a tool worries me slightly as a term in terms of it's something that measures everything and it fits everywhere. But I think a framing that guides discussion around this and makes it concrete is hugely helpful, and indeed is vitally important. We're not just trying to make the concept more complex and say it's not just about fragile and complex affected states, it's about a whole lot of other things. If we're challenging an existing narrow conceptualization of it, then it's incumbent on us to give some guidance, some framing that helps it be a useful tool for people, a useful framework for people to work out particular sources of vulnerability and how to address them. So that's very much our aspiration, not only ourselves, but to encourage others to be able to build upon this sort of conceptual analysis, both for local, national programming, but then in cross-national comparisons.
Perfect. I hope that addressed that, but definitely a valuable suggestion. One that I think now the work that has been done as part of this unit hopefully can make more attainable. We will move into our next speaker. Our next speaker is Dr. Stella Arakelyan from Queen Margaret University. Stella is a global health researcher specializing in the prevention and management of NCDs and population health promotion. Her current work focuses on exploring the social implications of NCDs for vulnerable and disadvantaged population, with an emphasis on access to health services in low and middle income countries. The title of Stella's talk is Trust and Social Connections in Contexts of Fragility. Stella, the floor is all yours.
Thanks a lot, Shadi. Good afternoon, good morning, or good evening, depending where you are. Today I'll be talking about what we learn about trust and social connections from case studies, looking at health-seeking pathways for NCDs in 3 diverse fragile contexts. Next slide, please. Nearly a quarter of people in the world live in fragile contexts. Those are the contexts that are marked by exposure to diverse risks that manifest dynamically over time, destabilizing communities and affecting people's ability to fulfill their potential. Additionally, as already Karin mentioned, fragile contexts are characterized by lack of state capacity, willingness, and/or resources to mitigate the effects of this risk and maintain the state core functions, which is ensuring stability, security, and provision of essential health and social services to its populations. This combination often leads to loss of state's legitimacy in the eyes of its population and erosion of trust in public institutions, including health systems. Next slide, please. To better understand the dynamics of relationship of the health system and community interface, researchers in recent years have increasingly turned towards the construct of trust. Trust is commonly defined in health literature as individual expectations for other party to act in their best interest. There is a broad agreement that trust is dynamic, intangible process, both based on mutual intentions, reciprocity, past experiences, and future expectations. Evidence coming mostly from high-income countries suggests that trust is a key driver of health-seeking behavior, and more specifically, higher level of trust in the health system contribute to higher utilization of health services, improved health-seeking from public providers, better adherence to treatment, and better self-reported health outcomes. On the other hand, compromised trust in health systems results in underutilization of public health services, care seeking for alternative, often more costly and less sustainable sources, for example, private care, informal care providers, and eventually over time may lead to suboptimal health outcomes. Next slide, please. Today, little research has been done to look at the role of trust in health seeking in context of fragility, especially in relation to non-communicable diseases, which on one hand disproportionately affect people in low resource settings, but on the other hand, because of their chronicity, they require continuity of care, in other words, repeated utilization of services for better management and control. And this might actually be very challenges to fulfill in fragile context. So we decided to draw on qualitative work completed by my colleagues in urban and rural sites in El Salvador, Sierra Leone, and Lebanon, to more deeply explore the role of trust in health seeking for individuals and communities affected by NCDs. Based on our analysis of contextual data, semi-structured interviews with community members with NCDs or their carers and healthcare workers, field notes, and causal loop diagrams that were developed as a result of group model building workshops. We developed a conceptual model showing the relationship between contextual factors, their impact on service delivery and utilization experiences, and how that shaped three types of trust: trust in institutions and institutional trust, interpersonal trust, and here we define interpersonal trust as trust in health providers, and trust in informal social connections, which we define as social trust, and how all this dynamics shapes future health-seeking pathways. Next slide, please. So this is the conceptual model we developed, and I'll try to explain it in a simple way. So in the left side, we describe how fragility impacts state capacities, capabilities, and governance within each context that directly affect the accessibility, affordability, effectiveness, and quality of care services offered to the population, as well as shaping broader institutional trust in public health system. On the right side in green, we acknowledge how positive experiences of utilizing care at specific sources work over time to influence perception of quality and effectiveness of specific providers. In a way, it's interpersonal trust in health providers. So this feedback loop describes how interpersonal trust in health provider can facilitate health seeking from those sources that provide consistent, positive experiences and perceptions of good and effective quality of care. In pink, we acknowledge the role of informal social connections in shaping future health-seeking pathways. More specifically, we note that experiences of health service utilization and also health status improvement are communicated to informal social connections. And this information, alongside the social cultural beliefs and norms that dominate or prevail in particular context, may shape the views and future advice of the social connections on health-seeking pathways in a way that social trust, which is trust social connection, can facilitate health-seeking through trusted social mediators and linkages with health services. And particularly in terms of linkages, we acknowledge the role of community organizations in one of our contexts, which was El Salvador, where community organizations were actually very active in identifying people at risk and linking them with public health services. At the top part, I already mentioned, but we also acknowledge that institutional trust is affected by wider state capabilities and governance approaches, and potentially can be strengthened by power sharing with community organizations and facilitating their engagement in decision-making in issues affecting daily life of their communities. And this was also based in our El Salvador example, which was slightly deviant case compared to Sierra Leone and Lebanon. Next slide, please. So overall, just key findings like the dynamics of how health services are delivered and experienced by communities shape institutional interpersonal trust and future health-seeking pathways. However, beyond those experiences, historical narrative about public institution and state authorities' responses to fragility drivers impact broader institutional trust and therefore utilization of services from those institutions that state represents. And the third point, that social trust can facilitate health-seeking behaviors through social bonds and linkages with health services. Next slide, please. So based on our findings, we highlight that there is a need for measures to rebuild and maintain trust in public health institutions and providers in fragile setting in order to better control and manage NCDs. This is not obviously easy, it's a complex initiative and will require multiple interventions at multiple system and community, district, and national levels. But we acknowledge the key targets. So key targets we think should be consistent investment in health services to ensure equitable, affordable, person-centered NCD services at community level. We acknowledge the importance of establishment of strong collaboration with community organizations, including, for example, in rural communities, village committees, community leaders, and people affected with NCDs, and facilitating their participation in health decision-making around issues that affecting their daily life, but also involving them in developing feasible mechanisms for facilitating their access to health services. And third, which is really important, is capacity building of both health providers in order for them to be able to provide person-centered services, improving their communication skills, competence, but also empowering communities themselves and people affected by NCDs in order to give them power and voice, safe spaces so they can voice their concerns and issues affecting their daily life. This obviously, as I mentioned, are complex set of interventions and might not be achievable without first strong political will, but second, targeted financial investment from donor organizations, which also would be good if help capacity building of the state institutions. Yeah, that's me. And the last slide, Karin, if you share, it's just the references for the case studies that we use for this analysis. So I think the copies of the presentation will be shared so you can have an access and read on your own time. Thanks a lot.
Thank you, Stella, for an interesting talk. And definitely this is sort of the first application within the context of fragility in the program. We have a question that was asked by Ms. Jomana Eid. Jomana asks, I think it's can be answered by any of the speakers. What do you think is the most important thing we should strive to develop regarding mental illness? So this is the first question. The second is the availability of treatment and access to it or updated the system related to access to treatment and care? I'm not sure that I understand the second question, but I hope that it's clearer. So I'll say that again. The first is, what do you think is the most important thing we should strive to develop regarding mental illness? And the second question is the availability of treatment and access to it relates to access to treatment and care? So I see that Alastair has opened the camera, and definitely Alastair can start. And I would also use this opportunity to remind all that we will have a specific session dedicated to mental health tomorrow as well. Alastair.
That was going to be my main steer, actually, Shadi. So, Jemina, thanks so much for the question. And at the same time, tomorrow, we have a session explicitly, just as Shadi has said, addressing issues of mental health and service provision. And I think in the context of that, the answer to your second question would be often both, in terms of there are issues of access to existing services, but a lot of our work has been reflecting on the barriers, not just circumventing those barriers, but understanding ways of making services more user-friendly and more reflecting the needs, the expressed needs of local populations. So I think it's a bit of both, Jemina, and it links to issues of trust, the sort of thing that Stella was talking about, but we'll be more fundamental looking at that tomorrow. That's all I wanted to say. Thanks, Shadi. Thank you,
Alastair. Anything to add, Stella, Karin?
I think maybe availability of services as well. It's both availability and accessibility. So I think from the work of Sierra Leone, the colleagues were mentioning that I think services are not actually there. Let's start with that. And if they are there, they are not accessible to people. Yeah.
Okay. Thank you. I think we can now move to our last talk of this session. The title of the talk is Unspoken Fragilities, Navigating Trust and Connection Within Psychosocial Networks in Post-War Sri Lanka. The speakers are Dr. Ananda Galappatti from the Good Practice Group in Sri Lanka and Dr. Ellison Strang from Queen Margaret University. Dr. Ananda is a medical anthropologist and a practitioner in the field of mental health and psychosocial support in situations of conflict, disaster, and poverty. His work in this field over the past 18 years has been concerned with strategic interventions to improve access to knowledge and skills, build collaborative networks, and enhance coherence within the field in Sri Lanka and also globally. His interests span the provision of MHPSS emergency responses, integration of MHPSS into post-emergency reconstruction and development, care and protection of vulnerable children, responses to gender-based violence, and services for people with serious mental illnesses. On the other hand, Dr. Ellison Strang is a psychologist whose work addresses the needs of people affected by conflict and disaster. Since 2000, she has been involved in applied research concerning impact of humanitarian crises on the mental health, psychosocial well-being of communities and individuals. With Ananda from Sri Lanka, she co-founded the Mental Health and Psychosocial Support Network aimed at shaping good practice and humanitarian responses by providing a global platform for connected people, networks, and organizations to share relevant resources and expertise. After this introduction to both our esteemed speakers, the floor is all yours.
Thank you so much for your introduction, Shadi. So Ananda and I, you've heard a little bit about us, but we decided that our presentation, we would make it in more of the form of a conversation. So that's what we're going to have, a bit of a dialogue, and Ananda will be illustrating some of the work that he's been doing as part of the Research and Fragility unit. So we've been collaborators for many years, and I would say, Ananda, I don't know if you would agree that probably what's driven our collaboration is a shared interest in professional networks, particularly within the mental health and psychosocial support field, and also driven perhaps by the values of inclusivity and the aim to enable and equip. So given that kind of work together, I wonder if you could just tell us a little bit about the period immediately after the tsunami, when I know you were working in the east coast of Sri Lanka, badly affected by the tsunami. And that was a period when I remember you being very active in starting to explore this whole challenge of effective networking. So tell us a little bit about that, if you would.
Thanks, Alison. I wonder if we could have the next slide, please. So you're very right, Alison. You know, the period after the tsunami, many of you will remember. Some of you were actually present. Some of you in the room were actually present on the East Coast during that period. Were overwhelmed by not only tremendous needs, but also an unprecedented number of responding agencies and groups. And coordination has always been sort of the Achilles heel of humanitarian action. So this is the first time I was sort of really actively engaged in large-scale coordination, trying to address issues of duplication and providing guidance to improve quality, but also together with colleagues, particularly those with sort of deep local knowledge, trying to help people navigate a complex context which is not only a site of a major disaster, but also an ongoing conflict. And we had sort of overlapping jurisdictions of local government authorities, national government authorities, local NGO consortia, UN-led humanitarian coordination bodies, and even sort of tacit militant influence over the activities of local actors. And our coordination mechanism, I think at the time we did what we could, especially in this space that was created by the chaos of the tsunami. But as the conflict escalated and the humanitarian space shrunk, we actually had a lot of difficulty maintaining an open and neutral coordination space in a context that was increasingly saturated with difficult politics. And so we actually wound up preemptively closing it down rather than have it be taken over by a party to the conflict. And we were actually quite relieved that we did this later, when at least 2 other coordination groups in the island succumbed to some version of that fate. So certainly a difficult context.
And illustrating many of the points around fragility that the other themes of work have elaborated for us. So, but let's fast forward now another 10 years to around 2018, which was a time I know when actually you founded another initiative, perhaps with some similar aims, perhaps with some different ones, a community of practice for knowledge exchange. Why were you willing to give it another go? And how were you hoping things would work out?
Okay, have the next slide, please. But so 10 years later, willing to give it another go because the context was less volatile. It was still politically contentious, and there was a real need in the field. The field was very fragmented and depleted, with sort of limited cooperation and exchange between agencies and across the sector. And so we actually, coupled together a number of key institutions with some institutional memory and commitment to a more coherent field, and quietly established a community of practice for MHPS's knowledge exchange that was trying to bring together technical personnel from different institutions and different sectors to kind of build some sort of common understanding and sort of facilitate professional kind of linkages and trust between them. And the emphasis was very much on creating spaces for informal exchange, where we privileged professional identities over institutional ones, and where there was space for critical reflection. And we often invoke the Chatham House rule in our gatherings. And this community of practice grew over a couple of years to host at least at peak sort of 170 practitioners from across civil society, private sector, and state institutions. And it worked through sort of both in real life and virtual spaces, and I think really came into its own in terms of supporting the response to the 2019 Easter Sunday bombings and the pandemic response in 2020 last year. And it seemed to be working really well and surviving and seemed like a good model. And so we were really curious at that point to try and understand its impact, the impact of this model on the field and work in Sri Lanka, and maybe see how it might be applied elsewhere.
Mm-hmm, mm-hmm. And so that, as I understand it, is where you were then pleased to find the opportunity to work with the research unit on health and fragility.
Yes.
And so in the past year, you've had that opportunity to address some of those key questions. What were the kind of key things that you wanted to learn about in your collaboration?
Could I have the next slide, please? So I think what we were really interested in understanding was how this community of practice was impacting on the connections and trust within, actors across these different institutions and sectors, what the key social connections were that mediated these relationships, and how these enabled cooperation, and sort of what impacts this had on the quality and provision of accessible services. And yes, we were really fortunate to be able to partner with RUHF through mhpss.net and the Institute for Health Policy, and my colleague Zainab Ibrahim and Milishka Pereira, who are also in the room, really did most of the heavy lifting in terms of the field work, because I also had to exclude myself from certain elements of data gathering and even preliminary analysis, because I was also playing a central role in the network. Maybe I could just describe a little bit the study that we undertook. So on the next slide, please. We really took a sort of a mixed methods approach that was very much reliant on the social connections mapping methodology that had been developed by Queen Margaret University. And of course, we were working in the context of COVID-19. So we need to adapt this for remote data collection. No possibility of face-to-face workshops. So we had an initial sort of exploratory survey that helped us identify the key social connections within the networks, to see who would people reach out to for a diverse set of needs. And then we used the online web app version of this social connections mapping tool to sort of measure the levels of contact, reciprocity, and trust between participants and the top 20 connections from a total of 127 that we'd identified. And then my colleague Zainab then conducted in-depth interviews with about half those respondents, selecting individuals to maximize diversity of social and professional backgrounds, experience, and engagement with COP, to really dig deep to understand what it was that they were getting out of it and what was enabling and perhaps hindering these connections.
Yeah, great. And we've only got a few minutes left, but Ananda, it was very interesting for me too, having been involved in the development of the tool, and you were applying it in a new context, which would be a closed network, looking at the dynamic within. So we've just got enough time to give you a chance perhaps to tell us the headline findings and some of the implications that have come out of that study.
I'll try to be brief. So it was really helpful to bring together this sort of the material, the insights. We learned that the network was there were many positive things about it, and you can see that on the slide. People felt it really changed their work, but we found that using the mapping tool and also the in-depth interviews to try and understand that why were certain connections crucial nodes within this network, why were others less trusted. We were really challenged by this, not because of what we were finding out, which is very interesting, but really about the challenge of reporting on this in a context where it was very difficult to give any level of detail and specificity without potentially revealing to those in the know who these actors might be. But also crucially, we realized that some of the roles played by these key actors were associated with very sensitive functions that were all often about maintaining an inclusive space or preventing instrumentalization of this COP, protecting the space from external conflicts or disputes, or with other stakeholders from the field. So that's really caused us dilemmas in how much or how we can report some of these more sensitive or or hidden dynamics in this closed system, as you described, without inadvertently causing harm to either individuals or to the collective space we were studying. And to make the link to sort of the issue of fragility, next slide, please. I think perhaps the most important thing, that almost revealing thing that from this study was that it highlighted, even to, I think, some of us, including myself, who are very embedded in the COP, the extent to which the facilitation of this community of practice by its key movers was actually centrally concerned with navigating what we were referring to as unspoken fragilities that sort of permeate and surround the field of MHPSS. So there were, for example, long-standing tensions between state and civil society actors in the field, which originated in the time of war, but have continued since then. We've had, participants, mentioning ongoing tensions between the influence of more psychiatric approaches and actors who are maybe associated with more broad MHPSS perspectives. There's also risks associated from overly bureaucratic and regulatory frameworks that could jeopardize diversity and pluralism. And of course, we're also operating in a context of a constantly changing political context and even a policy context, whether this is, we had a constitutional coup, we had public apathy towards post-war reconciliation and recovery services, and then a very charged environment after the Easter Sunday attack. So, we realize, and then maybe this relates to what Karin was talking about earlier, that, we see the kind of fragility that the COPs are navigating in terms of kind of uncertainty and risks and stresses associated with dynamics both within the health and social care systems, but also between these, and both sort of environmental stresses and sort of macro state or societal level governance structures. And I think our takeaway was that, institutional memory and knowledge held by key individuals, often these nodes, were really critical to their ability to help the community of practice and the field implicitly navigate these dynamics and this wider political context. And this has implications for, work around coordination and leadership in a field such as MHPSS in a fragile or emergency context. So we're sort of trying to apply some of those lessons now.
Thank you very much.
Thank you. I think this was a very interesting talk. Thank you, Ananda, and thank you, Alison, for also mixing and matching the format and having this be more of a discussion. I think the floor now is open for Q&A, but I will start off by a comment that was actually made by Alastair, saying that there were some interesting parallels between that history that Ananda outlined and that with Comas colleagues witnessed, and that with Ebola, and that we have witnessed here in Lebanon and the region with other colleagues, especially with the influx of Syrian refugees and the complex influx of actors in that. Alastair, would you like to say more on that?
Briefly, yes. I mean, and it's more a question for you, and I think Hajar's not with us, but maybe a reflection from Ms. Karin, because I took two things from what Ananda was saying. One, a sort of a structural one, which I find reinforcing of our earlier analysis about, yes, the state, civil society dynamics, intermediate dynamics, and so on, and that's very prevalent in our work. But it also struck me by that sort of the hiddenness, the privacy of it, the unwillingness, understandable willingness to, there's nodes, there's individuals that are lubricating that system and so vital. And it made me, and he's not hidden, so I can mention Rabia, for example, in Beirut, that it strikes me, this is who leads the mental health response, has key skills in terms of connecting political economy skills or political skills within the state system, but also managing that sort of influx of NGO and broader interest. And it's the sort of thing that gets missed out of analyses of service response, but seems to be from the outside are hugely crucial, that there is people skilled politically, and that goes back a little bit to Karin's diagram of that interface. I'm particularly interested really in service provision at the bottom level, but I recognize that what enables or disables that are a lot of broader political economy factors and broader political factors that shape the capacity to do that. And both Ananda's presentation and some of the other comments have pointed to the importance of political skill, leadership, facilitation, subtlety. That's all the things you were talking about there, Ananda. So you're partly nodding, Shadi, but I'd just be interested for you to elaborate with the role that you see for that in the current and recent crisis in Lebanon, in terms of the fragility of the country and how it's been managed in terms of various systems of provision.
So I just would like, I will answer that, but I would just like to remind all of our participants to send their questions if they have any, in either the questions or in the Q&A. I will also make a pass to Karin to provide her insights into this, but Alastair, to respond to your inquiry, definitely, and this is not unsimilar to Ananda's experience in Sri Lanka, is that when it comes to MHPSS, and again, we will be talking about this in more detail in tomorrow's session, when it comes to MHPSS, the issue is that there's so much complexity in terms of actors, in terms of the context and the stigma associated with it, and in terms of the need for infrastructure and how does that play in sometimes in competition with other resource requirements. We've seen that in Lebanon, definitely. I hope Rabia is with us, but definitely the Ministry of Public Health in Lebanon, it was an uphill battle over the past few years to sort of integrate, monitor, and support MHPSS services, starting at the level of primary healthcare, but definitely MHPSS services are never as easy to start, coordinate, or build the infrastructure for as other types of services, whether it is NCDs, whether it is other types of diseases, definitely. And I'll will ask Ananda to say more about that as well as Alison, but also want to hear from Karin and with the modeling that has happened for MHPSS, whether you have also seen that when it comes to all of the inputs, all of the actors, and what did the models show?
Yeah, thank you. I'll take that first, maybe. I think it's interesting and relates partly to, I think, a question Jumana was asking earlier around what comes first, but equally what Alastair was emphasizing, who's leading what comes first, or who determines what, and also emphasized. So I think a lot of the modeling, what was interesting, was helpful in navigating a conversation or enabling a conversation about who influences what and why. And what was particularly interesting, I'm maybe going to reflect on the Lebanese case, our participants, when coming together, I think were able to get rid of quite a few discontents that they had, potentially thinking that they were competing in some way for resources, or that the resources, I'm thinking particularly, there's a lot of work that you yourself will speak about, Beirut versus Bekaa Valley, so rural versus urban environments. But once they started speaking to each other and realizing how they connected with each other and equally how they could mobilize, it was interesting to see that actually they saw entire pathways, not just of referral, which would be the kind of service delivery element, if you like, but of advice, coordination, of building capacity. How could they get together to support each other in different ways? And that was happening, what we, again, in the modeling work saw both at the kind of macro level as well as the lower service delivery level. So people at clinics suddenly saying, oh, okay, I didn't realize I could connect with you about this, but now I'm going to do that. The one thing that kind of came up through those narratives is what you're saying around sometimes there is a very clear competition between programs. So it very much depended on how MHPSS was positioned. And even within that, like Ananda, also you emphasize the psychiatric versus the public health, maybe rationale that some people took. And again, it was interesting to see that actually once they had that conversation, it was easier to say, well, this is where your remit starts, this is where our remit ends, and how they could coordinate more effectively around it. So oftentimes it seemed the modeling just provided an avenue really for that conversation to happen. But I wondered if those kind of conversations shouldn't happen more. I think that's a reflection on us. We kind of did it as part of a project, but maybe that's something that should continue as part of routine work. I'll just stop here.
Thank you, Karin. I will give the floor to answer for Ananda, but I will add to that a question that we also got for Ananda from Shashika Bandara. Shashika is asking, how do you see the mental health support landscape in Sri Lanka evolving? And also how networks such as MHPSS can become integrated into the health systems further?
Thanks, Shadi, and also thanks, Shashik, for that question. I think very carefully, I think, is the answer in terms of how one engages, and perhaps taking the perspective of MHPSS.net as a not so much my position as someone embedded within the Sri Lankan context with MHPSS.net as a global platform that seeks to support networks and responses in diverse contexts. I think working very closely, of course, with other colleagues, for example, the IC reference group and other structures. I think what's really crucial is an understanding that we're going into contexts that are not neutral terrain, where there are often long histories, sometimes very contentious histories that are both at the level of personal interest, institutional interest, political. There is a complex political economy, let's say, around MHPSS, just as there is about many other things. MHPSS is particularly complicated because it's a multidisciplinary, cross-sectoral kind of area of work. So therefore, the dynamics are just, the complexities are multiplied because of this. But I think crucial to this is a sort of a healthy respect for local actors' insights and guidance, and the need to recognize that there are good faith actors and bad faith actors in these contexts, and that they may all be playing politics of a different sort, but some of them are playing a more inclusive politics, and where one can align with and enable spaces that allow for inclusion, for the kinds of conversations that Karin was talking about, where people are able to evolve from the positions that they perhaps earlier had, or use the opportunity of a crisis to transcend some impasse that existed, or for people to reinvent their positioning. I think that's the sort of the art of it, and I think that's where perhaps it's not just sort of, it's a combination of tapping into local political understandings and knowledge of the unseen, and being able to ask about that and work with that, but also having the tools and skills and methodologies that allow you to create spaces within which trust can be built, whether it's at a very much a local level or at a national kind of ministerial, interministerial level. So my take on that would be that, this is about a set of skills that, people coming in to do coordination, coming in to help lead or shape humanitarian responses, or coming in support of government or kind of communities there's a repertoire of skills and orientations that they need to have. And maybe the sorts of frameworks that Alastair was talking about earlier about mapping some of these dimensions of fragility could be useful when applied to MHPSS coordination. Over from me.
Okay, thank you, Ananda. Now we move into a couple of questions that we received on the issue of trust. So, discussion, interesting presentation by Stella. The first is from Kathy Pike. So Kathy is saying that she is struck by the reference to trust. She says that we see issues of trust as being critical to every level of the work, individual level, organizational policy and systems. She's asking, what do speakers recommend in terms of how we can best measure trust? And the second question is, what do speakers see as the best strategies for building trust in relevant context? I think by relevant context, and for the sake of this session, she perhaps means fragile context. So again, the first question, what do speakers recommend in terms of how we can best measure trust? And the second is, what are the best strategies for building trust? Stella, would you take a first stab at this?
Yeah, I mean, most of the trust measures obviously are coming from high-income countries. That's a well-established fact. And if you look at the way of measuring trust in public institutions, is mostly around, and specifically health system, is mostly around provider and patient relationship, and specifically looking at, you know, communication styles of provider, how attentive the providers are, their competence, their communication style, their confidentiality, their fairness. However, recent literature, specifically, for example, Ozawa is arguing for, there is a need for looking on broader health system, not only provider and patient relationship, but how things are working within a system, including the policies and the context it is embedded in health systems. So it's not only, so health system and providers are not working in vacuum, they are part of the wider context and everything that coming from political institution, how they channel funding, how they you know, develop how they develop protocols for training health providers and financing the health services. It all impacts on one health service and further on the relationship of people who are working in a health service with providers. So from that perspective, you should have take into account the context as well. I mean, we can do some literature review and develop the items for that, but what is available now is not enough. It's not measuring really trust in the health system on specific aspects of it.
Okay, thank you, Stella. Actually, I would like to add something related to perhaps what we've learned from also COVID-19. I mean, from COVID-19, we learned that, so it's not enough to look at trust at only the level of the healthcare system. It's the level of country governance in general. So if you look at COVID-19, it is countries that the overall trust in the governance structure, when it was high, it resulted into more compliance of citizens with governmental mandates, right? The example of New Zealand, the example of, you know, Sweden, whether we agree with that or not, but those, there was a high level of trust in this political system itself, which resulted or trickled down to that of healthcare decisions. Whereas in most countries with fragile settings, I don't know if it's a direct relationship, but in most of these countries, the level of trust in the government itself is rather poor, and hence it trickles down to trust in healthcare delivery, organization, and so on and so forth. Even if you had a good minister of health, she or he would have, in those contexts, an uphill battle to gain the trust of individuals within their own respective country, compared where the level of trust in other countries where the level of trust in the government is high. So I think trust in healthcare has to be seen as, you know, or factored in when the level of trust in the government itself shows. I think all of the modeling that has been done or will be done will have to factor that in as well. Would any of our speakers would like to add to that before we move to the second question? Alastair, you are muted.
Just very briefly, just for Kathy, the Alison, I think, who's now left us, but I think has done some very interesting work looking at trust and measuring it in the sense of different situations. Would you trust this person for this or for that? For example, sharing experience of gender-based violence, or borrowing some money, or asking their advice. And they're very different things. And I think this disaggregation of different aspects of trust is something that's just becoming increasingly apparent. It's not one well of either very trusting or not trusting people, but it's very much invested in particular parts of a system. And I think the more challenging thing, Cappy, is how to build it. And I actually find Stella's diagram very encouraging in that regard. I love those feedback loops that begin to suggest, okay, this is the mechanism that would strengthen social trust, or this is the mechanism that would build institutional trust. So I think we're very excited to explore the implications of that analysis over time.
If I might just jump in, I think, you know, what you said, Alice, also resonates with some of what we found in terms of, you know, who people turn to is very much related to what they're looking for. And it's, but I think there's also I think there was a resonance between what we were seeing perhaps in the narratives around trust that we were seeing in this particular mapping study in the community of practice that echoed, I think, with my master's research around health-seeking behavior and choice of kind of within plural health systems in Sri Lanka. And I wonder whether there are also maybe perhaps culturally specific or kind of emphasized aspects of trust, which their trust was very much based on track record. It was based on what had happened before and how people had treated you or what they'd been able to do and what trusted people said others had done for them. And so there was a sort of socially transmissible kind of chain of trust, but it was also very much around kind of people within the community of practice were more likely to trust and turn to those who they'd worked with, known intimately, had studied under, or were somehow related to. And I think that's something also maybe worth considering about cross-cultural kind of constructions of trust.
Okay, thank you, Ananda. I think we still have, I know that we're nearing the end of our time. We still have a few minutes left, but we have a question from Barbara Kamals. Barbara is asking actually an important question, asking from a point of view of trust, what is the best way for people external to a culture or society to contribute expertise? Specifically, she's saying that she has extensive experience in the US with cognitive deficits and their impact on families and societies. And she would like to share that expertise with countries with less resources, specifically when it comes to studying elderly. Specifically, she is working in Nepal. So I think the latter part is a comment, but the first part is also important. So for the speakers, from point of view of trust, what's the best way for people external to a culture or society to contribute expertise? And I think I will start off by saying, given our sort of partnership between us, COMAS and QMU, it was actually starting to build trust within the partners themselves, and I would be honest and transparent to say that when this relationship started, it wasn't an easy relationship to manage I think on all parties. I'm not the easiest person to deal with. So I think Alastair is smiling, so he knows that. But actually, once all of us have reached a level, the partners, of trust amongst one another, I think I personally have enjoyed us as based in Lebanon, the Global Health Institute. We have started enjoying the partnership more, and actually our productivity and working together has increased. Karin and Stella, Alastair, Sophie, we've been working very closely. And I think that issue of trust has to sort of evolve among the partners. And then from there on, it becomes easier. I will give the floor to both Alastair, who smiled as I was saying, I'm not the easiest person to work with, and then Karin, who experienced that, to say a little bit more.
Yeah, just very briefly. So thanks so much for your question, Barbara. I think it's a really important one that is recurrent in our work within the Institute with the multiple of partners. And Ananda will be familiar with work we did with the Psychosocial Working Group a decade and a half ago, which very much influenced me in terms of the short answer to your question is listening, I think. And it's about trusting your expertise. I think it's really great that you have expertise to share. And I think you will be able to share it. And it's probably better for, if I use the term Southern colleagues like Shadi or Ananda to really describe this process, because I have a power of a Northern institution, in terms of determining the way that relationships and partnerships deliver. So I think we have got something to offer, but I think Ananda used this framing of safe spaces or open spaces. And I think it's just allowing those to develop and listening within them. And those safe spaces are often, if the theatre of your concern is Nepal, it's for the Nepalese to create that space. And I'm sure there will be opportunity for you to share your expertise in that. And yeah, that's probably what you're already doing, Barbara. Ananda switched his camera, so I don't know if Ananda, you want to comment briefly before we go to Karin, but that would be my lesson learned, I think, Barbara, over the years.
Yeah, I would concur with you, Alice, but I also think that it's about time to get to know one another. It's about trust is not just I mean, I can trust Alastair's expertise, but to trust Alastair as a person, as a partner, requires other kinds of interactions. And I know it's challenging to do this remotely via Zoom, but for example, the instances where we've been able to work together in country, collaborate on things, and I think I see sort of north-south collaborative relationships that are really fruitful as being those that have had time to sort of incubate and kind of evolve, where there's a greater understanding of the respective kind of strengths and gaps and blindnesses that we all bring, and so that's really what I'd say is but it's also that it depends on the fit. So it's not all partnerships are going to work out beautifully or last.
I will give the last comment to Karin, since Karin has been working with many of us in different countries and playing an active role, and then we will conclude this session. Karin.
Yeah, thank you. No, I'm going to just agree with the incubation comment. I think that's really valuable, but equally, it's the understanding and being very explicit about values. I think I've really liked that, and I think, again, even just reflecting on our relationship, knowing that AUB was establishing this institute, that you wanted it to grow, understanding that, where that was coming from, and helping with that vision or supporting it as far as I could, obviously, and our team could. That equally is important. And I think, Barbara, you made that point as well. There's something about trust between us as colleagues, but then in other work, and I know some of my colleagues from a different project are on the line, listening to those with less expertise is, I wouldn't even call it less expertise. They have expertise in a different way. I cannot navigate Lebanon or Sri Lanka or other places, but obviously you do on a day-to-day. And that is very different. And I have to not just listen, but equally trust you to navigate it for me in some ways, so that we can both grow in that way. So yeah, that's been definitely a lesson, and it's been very enjoyable.
Thank you so much. And I'll just add to that the last comment. And interestingly enough, it's Michelle O'Donnell who's saying this is, she said, an important comment, also the element of power in relationships and how that is shared to build trust. And I would agree a lot. I don't think that because we're a global South institution, Ananda is a global South institution, and there, Comas is a global South institution. It's always coming into this as a partnership where institutions of the global North coming in, wanting to achieve the outputs and outcomes of the project, but they're not sure of the capacities of their partners in the global South. So that takes listening and time. And us in the global South thinking that institutions in the global North are coming in with their ideas and agendas. Also, this is how it starts off, and usually there are a little bit of many conflicts at the beginning, but once both of these expectations and mindset are set to ease through, you know, working together, building that trust, I think once you reach that stage, the partnership becomes more enjoyable, and the output, the productivity, just exponentially increases. So I would add my voice to that of Alastair, Karin, Stella, Sophie, who I see on the call, as well as Alison, to you know, thank them all and also appreciate this you know, level of trust and partnership that we have established across the years. I think we are a couple of minutes over our scheduled time. I would like to thank all of the speakers. I would like to thank all of the attendees for their time, and I would urge all of you to continue to join the symposium, whether in the session this afternoon in half an hour, I think, on NCD, or tomorrow, a couple of sessions on mental health and population. So thank you all, and have a good rest of the day. Thank you. Bye-bye.
Thank you, sir. Thank you, everyone.